All right, welcome all of you to Introduction to Shelter Medicine. This will be part one of a two-part series. This is the outline for both sessions, and so there's a lot of content on here to cover. First, we'll just briefly do some high-level comparing shelter medicine and private practice. We'll talk about preventive medical care in the shelter setting. We'll talk about animal housing and handling and how that impacts medical, and then sanitation and biosecurity. Behavior in the shelter setting, very briefly, population management, and then we'll dive into shelter programs and how they impact medical and how medical impacts them, as well as important data and metrics in shelters, as well as a brief dipping our toe into the water of management of some of the really common diseases that we see in shelters. And probably even more importantly, along the way, I'll be sharing a ton of different resources. This is obviously a lot to cover in 2 hours, and there's just so many great resources out there, both from our team as well as other programs. And so really, that's my goal, is to just introduce you to some of these topics and point you in the right direction of more resources. So when you want to learn more, you know where to find that information. Okay, so first, let's look at comparing shelter and general practice. So what are some similarities to start with? So in both situations, we obviously have an individual patient in front of us, and we have a variety of treatment and management options with those individual animals. Evidence-based medicine, right? So in veterinary medicine generally, where we have evidence to support our decision-making, we want to use that evidence. And there is a growing body of research looking at basic diseases, conditions, or the impact of shelter programs on the practice of medicine in the shelter setting. And some treatments or management, right, those strategies that work in general practice may, for whatever variety of reasons, may not be the most successful option, as it turns out, in shelters. And so sometimes there are differences, but regardless, we try to make our decisions based on evidence. And then contextualized cares, meaning we as veterinarians, as veterinary professionals, we take into account the whole picture. That might mean what everyone involved with the care of an animal, what their goals for treatment and management are, the ability of those care staff or those caregivers to manage that animal. And so in a general practice setting, that might mean an owner. But in the shelter setting, there's an entire team, right, associated with the care of that animal in almost every single case, from the frontline care staff to other teams in the shelter to even shelter leadership or management, right? And in both settings, we take into account that entire context when we evaluate different options. What are some high-level differences? And so one of them, of course, is population health. And so in the shelter setting, we frequently are paying attention to not just the individual in front of us, but the entire health of the population, so that herd health almost. In shelters, we have to recognize the critical role that length of stay and that the subsequent stress induced by stay in the shelter plays on their health, both physical and behavioral health. And this has far-reaching implications in terms of disease management. We also make decisions with minimizing that length of stay in mind, right? The path to healing, the path to health is faster in a home setting than it is in the shelter setting. And for those pets that actually enter the shelter system healthy, shortening that length of stay is the most important thing that we can do to keep them healthy and to move them through that shelter system as quickly as possible. We make decisions with resources in mind, and to a degree, this can happen in private practice settings as well, but particularly in shelters. And it's recognizing resources aren't just financial resources, right? It's also things about staff time. It's about facilities, for example, housing resources. And so resources frequently are at the forefront of our decision making, trying to balance that and resource allocation across that entire population. Operations impacts medical and medical impacts operations. So we have to recognize this interdependency between these different departments in the shelter and really strive to collaborate to make decisions on cases. The veterinarian is not the sole decision maker in this setting. And really, this is not unlike GP, where the owner plays a role in that decision making as well. That is very similar, in fact, to the shelter setting. It's just that instead of an owner, it might be leadership, it might be management, it's folks on the operations team or folks on the care team. And then life-saving capacity. So our goal in sheltering, right, it's not just a positive outcome for that individual. Of course, that's part of it, but it's also a positive outcome for as many animals as possible and for our staff and taking into consideration our staff well-being along the way, right? It's so much more. than just that single pet in front of us. And so I think about all of the lives that we can save. All right, let's dive into the medicine. And so we will start with preventive care. So what do we need to do to keep animals healthy that are entering our shelter systems? First, we'll talk about vaccines, right? If I had to pick one pillar of preventive care or of disease prevention in the shelter, probably vaccination is at the top of that list. And so when we think about shelter vaccination strategies, we want to vaccinate on intake or before intake if that's possible. So for example, if we're scheduling out those intakes, can we vaccinate a puppy today, send it back home for a few days or for a couple of weeks, and then bring it back in time for its additional dose, and then admit it to the shelter facility? So maybe that vaccine gets some time to kick in. Whenever we have the option, we want to choose modified live vaccines versus different types of inactivated vaccines. They work, they stimulate a stronger antibody response and they work faster. And that's going to be really important when we're thinking about high risk shelter environments. We vaccinate according to a shelter specific schedule, which I'll go into more detail here in a second. And we want to make sure that we're storing and handling our vaccines appropriately. If we are not keeping them in the appropriate temperature, if we're not mixing them appropriately, they're going to lose efficacy. And then medical records and reminders. We want to make sure we're using our shelter software to ensure that we're giving those vaccines on that appropriate schedule. And so what is that schedule? Well, so for GHPP for dogs and FERCP for cats, current published shelter guidelines say that we should start at 4 weeks of age. However, there are broadening recommendations coming out from shelter medicine academic programs and many, many shelters that are exploring and have been practicing vaccination even sooner than 4 weeks. So even as young as a day old. So we're calling this neonatal vaccination. And really in a nutshell, it's because shelters are such a high risk environment. And if we're putting puppies and kittens at meaningful risk of being exposed to infectious disease, and there's a chance that these vaccines will be effective early. So let's give them that chance. We vaccinate on a narrower interval, so we vaccinate more frequently, so every 2 to 3 weeks for our puppies and kittens. And if they're in the shelter building and I have access to them, it's 2 weeks on the dot. And then we keep vaccinating out to 20 weeks of age in most cases, or even longer. A difference from private practice and for shelters is for adults, we're going to typically give a second dose of vaccine, whereas we don't always do that in private practice settings. And so, yes, I just want to reiterate, as early as 1 day of age in situations where we believe there is meaningful risk. Dogs are going to get Bordetella and para-influenza. Again, choosing a modified live is going to be important here as well. We have better evidence for efficacy for our intranasal versions, and so we're going to choose that intranasal. And that one they get at intake. Some of these vaccines are labeled at 3 weeks of age, so by 3 to 4 weeks of age or older if they come in older, and then they'll get that vaccine annually. And then rabies, right? So rabies is typically required by law at some point for dogs and sometimes for cats, and it's going to differ based on jurisdiction. So for some places it's 3 months, for some places it's 4 months. I have a plus or minus here because this disease, with rare exceptions, is not a disease that animals are going to be at risk for contracting while they're in the shelter. And so yes, we want to give it before they go out into the world, but it's not one that we have to give on intake like we do with these others where we worry about them catching those diseases in the shelter. A brief note about juvenile vaccination. So remember that if a mom, so a mother cat, mother dog, was either exposed to or was vaccinated for a particular disease, she will have antibodies to that disease that she can then pass on to her puppies or kittens. That happens with early nursing, and those puppies and kittens can only absorb those maternal antibodies for about the first 24 hours. So they get this pile of antibodies if mom was protected, and these antibodies decrease over time. Because the amount that each puppy or kitten gets can be different, that rate or how fast those maternal antibodies go away is variable. While those antibodies are high enough, they provide protection, but they also interfere with our vaccines. And so the vaccines that we're giving, if maternal antibodies are hanging around, are not going to provide that long-lasting protection that we want them to. One thing we do know is that maternal antibodies are gone essentially by 16 weeks of age in every puppy or kitten. But what this means is vaccines given before then may or may not have efficacy. Maybe they're effective, but maybe they're not, right? And so we cannot consider puppies and kittens protected. We can't know for sure their vaccines have kicked in until they've gotten at least 2 vaccines, both given at 16 weeks of age or older. And so this means when they're 18 to 20 weeks of age and they've gotten both of those vaccines. And so something I hear in the shelters often is this X weeks old puppy has had 3 vaccines, so he's protected. We don't have to wear gloves. We don't have to take extra precautions anymore. And unfortunately, that is absolutely not the case. Maybe that puppy is protected after that number of vaccines, but maybe he's not. And so it does not have to do necessarily with the number of vaccines they've received, but how old they are when they've received enough vaccines. So a question we ask in the shelter is who gets vaccinated? And so we'll start over here on the left, right? So here's a puppy and a kitten. Say these are 6 to 8 week old puppies or kittens. Do they get vaccinated when they come into the shelter? And the answer is yes, they absolutely do. By current shelter guidelines, 100% they get vaccinated. What about nursing moms? What about pregnant moms? And the answer there is they also get vaccinated. We want to provide protection for mom in the event that she's pregnant. If we're vaccinating early enough, we may even get some protection from those puppies or kittens if they are born in the shelter. What about animals with signs of infectious disease? So mild upper respiratory signs or even moderate upper respiratory signs that you can see in these pictures. And the answer there in the shelter environment is yes, we do vaccinate animals with signs of infectious disease. What I would not want is for this puppy to get parvo or distemper on top of his upper respiratory infection. And then lastly, I have some neonates. And so are we going to vaccinate these, say 2 to 3 week old puppy and kitten for with their DHPP or FERCP? And the answer there is in many situations, yes, we are. But that's a decision that we have to make looking at our own organization. Do we feel like there is meaningful risk of them getting exposed to parvo or panleuk or distemper? And unfortunately, with the current state of things in many shelters or even in foster programs, there is a real risk. And so we are going to vaccinate in those situations. And so the answer to the question, who gets vaccinated, is maybe it's everyone. And if it's not everyone, it's nearly everyone. We want to make sure we're storing and handling our vaccines appropriately. In shelters, we love these little mini fridges because they're so convenient and we can put them in convenient places like in our intake room or our intake bay. But the challenge is, we've all experienced this, sometimes they freeze things, or every time we open that door, all the cool air runs out. And so they are not oftentimes maintaining vaccines at an appropriate temperature. What does work better if you need something convenient is purpose-built medical grade fridges. So these are built to keep things at a stable temperature. And so they come in small sizes if we need something convenient. We want to monitor the temperature minimum and maximums. For any vaccines that we have to mix up, we want to mix them up immediately before administering. And if we have to take them out into the shelter, we want to use a cooler for transport, right? We're not just going to carry those in a basket and allow them to get warm. At the same time, we don't want them to freeze either. And if you experience a situation where the power goes out and your vaccines are not kept at the recommended temperature range, I recommend contacting the manufacturers. Sometimes they'll provide new vaccines for this in those extenuating circumstances. Here's some examples. You can see this condensation like inside the vaccine tray, and you can see this condensation on the back of the refrigerator there. And so this is what happens when the warm air comes into contact and that condensation happens. And so this is a big red flag that your vaccines are not being maintained at the appropriate temperature. So if you see this in your vaccine fridges, this is cause for concern. Some common vaccine questions, things that come up from the answers to these questions may be different than general practice. Can we or should we give vaccines to sick pets? And we address that. The answer is essentially yes, we do want to vaccinate. What I would hate for is them to get a vaccine preventable disease on top of whatever illness they already have. Can we give more than one vaccine at a time? And the answer, yes, is absolutely. This is something that in private practice, maybe we spread out some of those vaccines. But when we're thinking about shelters, we have an opportunity right in front of us, when the animal is in front of us, to vaccinate them. And so it's providing health services at that point of care. I have a chance now. I'm going to do everything that I can right now. Can we give DHPP, FERCP, and then rabies a few days later, or vice versa? And the answer here is yes. We have evidence and we have guidance from human literature that actually supports this practice. They can develop an immune response. And so again, if we have them in front of us and we have that opportunity, let's take that opportunity. Can we give vaccines at the time of surgery? Answer here also is yes. So we have veterinary literature that suggests they will respond to vaccines given at the time of anesthesia. And potentially any other questions that are out there. And what I would leave you with is that yes, when in doubt, vaccinate. And so we can pick, if there are other vaccine related questions, hang on to them and I can address them at the end of the talk. Feel free to drop them in the chat. All right, let's move on to other preventive care. So deworming, typically what we're going to do is pyrantel on intake, and in puppies and kittens, we're going to repeat that every 2 weeks. I usually do that whenever they're getting revaccinated. With puppies and kittens, I also like to administer panazeryl or similar drug. Toltrazeril is a same drug class. This is for coccidia. And the reason for this is because coccidia can just profoundly impact the health of puppies and kittens. In places where we see a lot of it, it is reasonable to go ahead and give a prophylactic dose on intake. However, that dosing strategy has not been established. A couple of different options on the slide there for you. Retroviral testing. So for FELV and FIV, we no longer in shelters recommend screening all healthy cats for these diseases. And so here's a little bit more on why. This was the 2020, so the most recent version of the AAFP retrovirus testing and management guidelines. And even in these 2020 guidelines, AAFP recognizes the desire to shift the burden of testing from the shelter organization to post-adoption. There are a number of reasons for this. When we have low prevalence of a disease and we're testing healthy cats, a positive test is more likely a false positive than a real positive, which means in this healthy cat population and nationally, prevalence of these diseases is typically around 2%, maybe 3%, depending on the shelter, depending on the region. But we're going to label a cat who does not have one of these diseases with a disease that, again, he doesn't actually have. And what does that mean for his adoption likelihood, for various pathways for him? There is confirmatory testing, but it's expensive and it's complex to interpret. And even with all the resources in the world, we don't always know how to interpret those test results. And so could we reallocate resources for initial testing and for potentially any confirmatory testing that we wanted to do to other life-saving strategies? And again, resources in this context, not just dollars, but it's also staff, it's time, it's stress on the cats, right? And so there's a lot that goes into this. Additionally, results are unreliable in kittens for both diseases. And a single test result, whether it's a positive test or a negative test, even if we knew for sure that it was a real result, right, it's still just a point in time. And a cat that is positive today can actually clear that infection in the case of feline leukemia. Or if the test is negative today, that cat could be incubating one of these diseases and test positive tomorrow or the next day, right? And so recognizing a test is just a single point in time anyway. And again, that especially when it comes to feline leukemia, this is a really, really, really complex disease. And this is a lot for the shelter to take on. And so if we shift the burden of testing from the shelter to the adoption setting to the general practice, where the general practitioner has the time and the space to have conversations with the adopter, do we even need to test? Do you have other cats in the household? Right. And then if they get a positive test result with the potential confirmatory testing with what those results mean, right? There's time and space to have those conversations. And that's just really impossible to do in the shelter setting. All right. Important part of preventive care is going to be spay and neuter, right? So let's talk briefly about high quality, high volume spay and neuter. So high quality, high volume spay neuter, when we talk about this, we think about programs that are efficient, programs that are safe. And it's both high quality and high volume. Our goal with these programs is the veterinarian remains in surgery as much as possible and has very little downtime. We want the vet doing things that only the vet can do, and that is essentially surgery, right? This typically means a staffing ratio anywhere from, in an ideal world, 3 to 5 staff per vet, or when I say staff, that can also be volunteers. So staff for volunteer or staff equivalents made up of volunteers, right? For example, utilizing volunteers in places like recovery or pack and prep can really augment paid staff. And a question that I oftentimes get, right, I have on the slide that it's efficient and that it's safe. And so there's that question, can we safely do 40, 50, 60 surgeries a day? And the answer is that yes, absolutely we can. This was a study that compared perioperative mortality in cats and dogs undergoing spay and neuter at a high volume clinic. And the study actually found that overall mortality risk was 10 times lower than for animals undergoing elective procedures in private practice or specialty. And this is not unlike what we find in human medicine, that when clinics and facilities focus on a single procedure, Surgical complications are also much less, right? And so we have better outcomes when we focus on doing a single procedure and we do it really, really, really well. And again, some of the stats that come out of this, they actually are mirror what we're finding in medicine, for example, for women undergoing elective reproductive procedures. And so the answer is that yes, high quality, high volume surgery is safe, sometimes potentially even safer. In order to facilitate this efficient and safe sterilization surgery, we oftentimes will use induction cocktails. And so we'll use combinations of drugs to induce anesthesia in an efficient way. We certainly stay on top of analgesia, so combinations of opioids, NSAIDs, and often local blocks. Our patient monitoring, so here's some examples of some of my favorite tools in the high volume setting, including pulse oximeters and these apnea monitors. And a question that oftentimes comes up, especially if your experience has been in private practice, is what about pre-anesthetic labs? And we actually have evidence that supports that. For an animal that is healthy on physical exam, pre-anesthetic lab work is not likely to change much about what we're doing. And so running pre-anesthetic labs on every single patient is probably not a great use of those resources and can drive that cost up when we're talking about our shelter high quality, high volume programs, or even access to care programs. So this is a graphic that I like to show when I think about high quality, high volume spay neuter, because I think of HQ HVSN at the intersection of all of these pieces. So it is safe for patients. We can provide very good patient welfare for both the individual and the population. When we think about sterilizing all of the animals in the shelter as they go out for adoption, when we think about providing surgery for community animals, we can do this efficiently. We can do it in a manner that's safe for staff and also provides positive staff welfare. And again, what I think about optimizing all of these in order to achieve those positive outcomes for everyone, including the animals, including our staff, the entire shelter, and sometimes in the case of the public services, we're even including the community in this. One thing that might be different from general practice is the age at which we're providing spay or neuter. And so we certainly are coming to recognize the importance of pediatric spay neuter, even in private practice, but it can be an individual decision, right? That is a discussion that's had with the practitioner and the owner. But in the shelter setting, we typically will pursue spay and neuter surgery as early as 6 to 8 weeks of age for our healthy puppies and kittens. Certainly, we need to take extra precautions when we're doing surgery that young, so preventing them from becoming cold or from their blood sugar to drop. Monitor them closely to make sure they're maintaining their heart rate. And I love these induction cocktails that we often use in high volume spay neuter because many of the drugs are reversible. So this might seem like a really young age. And the reason for this is in some situations, we can't adopt them or we can't finalize adoptions until they're spayed or neutered. And especially if we're housing them at the physical shelter, this is the most dangerous place for them in terms of infectious disease, right? They get exposed to disease, they get stressed, which can lead to more disease, right? And so pediatric spay neuter allows us to move them through that system sooner. Even in the situation where you're keeping them in foster care, we in shelters are limited by our housing space, including foster homes that have a maximum housing capacity too. And so if we have no kennels or no foster homes, then we are left with options to decrease our life saving, right? And so if we can move them through either the physical shelter or even through our foster homes faster, that potentially opens up our capacity and it increases it. And we'll talk more about population management a little bit later, but the key here is we want to move them through the system as quickly as possible. So what does that mean? We proactively schedule them for surgery. I will throw out just that 2 pounds is, I think, widely accepted across shelters, dropping it down to 1.5 pounds, becoming more and more and more widely accepted for both kittens and puppies, actually. And there's been no difference shown in complications when we do them at 2 pounds versus 1.5 pounds or 3 pounds versus 1.5 pounds. For kittens especially, it allows us to adopt them within their critical socialization period, right, which ends at 7 weeks of age. And so getting them out there into those adoptive homes can mean they're much better adjusted adults. And again, this has become a routine practice for many shelters. For folks that have reservations about it, I always encourage shelters to consider a trial and track your data. Like what are you seeing happen with your length of stay? Are you seeing an increased risk of surgical complications or problems, right? But we don't know until we start actually tracking that and looking at those metrics. Couple of excellent spay neuter resources, the ASV spay neuter guidelines, as well as this fantastic textbook that came out a few years ago that covers high volume spay neuter as well as other common shelter surgeries. Okay, let's look at housing and animal handling. So this is shelter medicine. Why are we talking about housing? Well, housing, what housing facilities look like in shelters affects animal flow and movement through the shelter, and that's part of population management. Population management, as well as the quality of housing, can affect disease transmission risk. It affects our staffing needs, it affects the stress of the animals, and all of these things impact the welfare of the animals in our care, and that in turn, right, is a part of their physical health and behavioral health. So I have some of the images from the Association of Shelter Vets Guidelines for Standards of Care in Animal Shelters. And so this is the schematic that looks at canine housing. And so I'll just call out a few of the key points on here, right? So it's double compartment housing with a transfer door in between. This allows separate spaces for eating and resting versus eliminations. You can see that there's options in this kennel housing. The dog can choose to interact with people that are walking by, or choose to interact with other dogs that it might see, but it can also choose to retreat, right? You can see, obviously, the basic needs are met with food and water. We have adequate drainage, and then there's enrichment in this kennel, right? Enrichment is considered non-optional in shelter housed dogs and cats. A key is, as much as we can, to provide choice, right? So providing that double compartment housing, the option to hide versus the option to engage, right? It allows the animal a sense of control over their living situation and over the activities that they're performing in that shelter. And so really key to positive welfare is going to be that option for choice. Sometimes in shelters, unfortunately, and like so many shelters across the country right now, we're facing capacity challenges, and it can be tempting to close the portals in your cat kennels or to drop the transfer doors and house a dog or a cat on either side of these doors. And unfortunately, what that means is that we are over capacity, right? Like these kennels were designed to have double compartment housing for a single animal, right? And so when we operate over capacity, we see increases in disease, we see increases in stress in the animals and in our staff, right? As our staff become more overwhelmed, it's nearly impossible to clean these kennels in a way that it's not stressful for the staff and for the animals, right? And this practice, unfortunately, is what leads to disease outbreaks time and again. And overcrowding is a known risk factor for disease. And so all of this is how it relates to the practice of shelter medicine in particular. But if we want to keep our animals healthy and happy, it is important to keep those transfer doors up and keep those portals open. Okay, so now feline housing, similar schematic, and so lots of the same things here. I would call it again, right? There's opportunities for this cat to decide to retreat or to engage with people that might be wanting to interact with him or her. Additional things that we have in the cat kennel, a theme is the ability to exhibit normal behaviors. And so you can see on here a scratching post for this cat, a perch, right? Again, it's about providing choice, and a hiding space is not considered optional for cats in shelters. So when I walk by a cat kennel that doesn't have a hiding box in it, to me, that's essentially the same as walking by a kennel that doesn't have water. So hiding boxes for cats need to be the same as food, water, and litter. Sometimes I hear staff worry that like adopters won't see the cats, and so they won't get adopted. But in fact, we have research that suggests that cats with hiding spaces are less stressed, and they actually exhibit more exploratory behavior when they have a hiding space. And so that actually increases their adoption likelihood, and we're providing better welfare for them because we're allowing them that space to decompress. And so again, hiding spaces are not optional for cats. There's lots of different ways to provide providing a curtain over part of the kennel or over that perch, where the feral dens or small animal dens are also excellent. We can retrofit kennels and put portals in after the fact if we weren't lucky enough to have double compartment housing from the get-go. And we always recommend doing that. Sometimes we hear though, but like we're going to reduce the number of kennels by half if we do this. And the reality is that yes, the number of kennels, the static number, is going to go down, but because your cats are going to be happier and healthier, or your dogs, if we're providing double compartment housing for dogs, again and again, when shelters actually make this change, the length of time that those animals spend in the shelter decreases. And so over time, we end up moving more animals through our shelter system. And I know that this sounds too good to be true, but I don't believe you. How do you know this will happen? It has been the experience of countless shelters that when they've taken the plunge, installed the portals, worked on reducing length of stay, right? With those animals, it's a system that feeds positively on itself. And so they stay healthier, and so they move through the system faster. All right, so let's talk about sanitation and biosecurity. So in addition to vaccine practices, this is equally important to preventing disease. And so let's dig in. All right, so sanitation. So when I define sanitation, this is the 4 steps associated with cleaning and then disinfection, right? So first we want to remove all of the gross debris. We then take a degreasing step, right? Then we disinfect. And this is where we have our disinfection agent. So rescue is an example of one of those. We want to make sure that whatever agent we're using we're using it for the appropriate contact time and at the correct dilution to be effective for the bugs that we care about. And then typically we want to dry those kennels before animals go back in. Wet environments can favor pathogen survival, and disinfectant, if there's any residue left, can be really damaging to animal skin or paw pads. We always recommend using a commercial dilution system, not just eyeballing it when we're generating those dilutions. And so this is an example of a foamer that has a nozzle that you can tweak the dilution to use it at whichever one you want for that particular product. But what we don't want to do is just eyeball it, dump it into the foaming unit and guess. These, if you're using rescue, precise indicator strips allow us to actually check, is the dilution of the rescue we're using the dilution that we think that it is? And so it gives you it's little strips that turn a color. And so you can see this is an example. This was a bottle that was supposed to be a 1:32 dilution. And you can see that pretty much matches that blue, if not turning almost purple, right? So maybe even a little stronger than that 1:32. And then this was an example of a bottle that I would say is not diluted properly. And this bottle, in fact, was in a space where there were parvo-exposed dogs and was being used to clean kennels of dogs that could potentially be in that preclinical shedding period for parvo. And so is that going to be effective against killing parvo? And the answer is no, it's potentially not, right? And so that's a problem. So always recommend quality control. Make sure your dilutions are appropriate. Sometimes we'll do this in shelters. And when we have known infectious disease, we hang up signs and we clean things 3 consecutive times. A key point is that if we are not disinfecting appropriately, I can put a new animal in the dirty kennel today or in 6 months, and it doesn't matter for hardy pathogens. That animal is potentially going to get infected, right? And so we need to make sure that we're disinfecting appropriately. We don't actually need to do it multiple times in order for it to be effective, right? If we're using the right product at the right dilution for the right contact time and it's making contact, right, it'll be effective that first time. The challenge is our kennels are not just like sheets of glass or sheets of plastic, right? There's cracks and crevices and there's bars. And so oftentimes when we know we have infectious disease, we'll do things like clean 2 or 3 times in order to ensure that we're making contact with every single surface in that kennel, right? Because we put an animal in that kennel tomorrow, right? We want to make sure that there's not any tiny, particles of virus left. Here's some examples of equipment being sprayed off, and I would ask, do we think this is effective? And so the rescue in these pictures is making contact with some of these surfaces, but certainly not all of them. That microchip scanner had just come out of a ringworm isolation ward, and this was how it was being disinfected. And so is that effective? And the answer, unfortunately, is no, right? We have to make contact with all of the surfaces that we need to disinfect. But we don't have time to disinfect between every single animal, and so what are some alternative options? And so doing things like just using a physical barrier, right? So a piece of newspaper that can reduce that pathogen contamination. And this is a cat, her name is Moana, and Moana says, don't let your scale be a fomite. Have other examples just of shelters, right? And so even after routine cleaning, right, you can see that there's buildup of debris in these kennel bars, or it can build up in places that we're not necessarily paying as much attention to. So in the chain link on top of this hand sanitizer, right? And even when I look at this kennel with these 2 little babies with the residue on the glass that you can see. And so they have upper respiratory, we have that evidence of that there, but so could pathogens be living in that residue? Sometimes we run into shelters that are using rescue, which is a great product, but we also see rescue wipes. And I want to call this out because I think it's a little bit misleading. So the actual packaging says virucidal 1 minute unless otherwise noted. And here is what is otherwise noted. Is 5 minutes. The rescue wipes to kill our hardy viruses like parvo and panleuk, we still need 5 minutes of wet contact time. And I would say that is really hard to achieve with a rescue wipe. And so maybe they will be effective against some of our less hardy pathogens, but for the bugs that we care the most about, like parvo and panleuk, things like ringworm, these are not necessarily going to be effective. If you want to look into more on shelter disinfectants. This great chart that's updated regularly from the ASPCA is a great reference. And so what I would call out is non-envelope viruses. These are our hardier viruses, and they're a lot of the ones that we care about in shelters. So parvo, panleuk, and calicivirus all fall into this category. And one thing that I would call out, so accelerated hydrogen peroxide is that first column, and that's rescue. Quaternary ammonium compounds are a class of disinfectants, and when independent research has been done, have been found to not be reliably effective in the shelter setting against these non-envelope viruses. And so it's important to recognize, even though these compounds come with names like parvusol, or they might say on the barrel that they're effective against canine parvo, they are not reliably effective against these pathogens. How do you know it's a quat? Because you can, quaternary ammonium compound, and you can see the name, the active ingredient, you can see ammonium in that name. And so just again, these are not reliably effective in shelter settings. All right, so sanitation. Certainly if we have an animal that is leaving a kennel and we're going to put a new animal in that kennel, we want to deep clean and disinfect that kennel thoroughly. However, if an animal is staying in their same kennel, when we have healthy populations, we can just spot clean. And this is really where double compartment housing is really convenient, because we can put an animal on one side, we can clean up really just tidy up that kennel, right? Instead of switching everything out and instead of fully deep cleaning. And that actually reduces stress. Biosecurity. So what does biosecurity mean? It's precautions that we take to prevent the spread of disease. And so what does that mean? It means hand hygiene, the use of personal protective equipment. So gloves, if we're doing close handling, maybe that means a full gown for animals with known infectious disease. Maybe that means a full Tyvek suit, like you can see in the picture there. So this was a shelter before this staff person was going into a respiratory ward. If we have low risk animals, but we still want to prevent the spread of disease, it can be as simple as throwing a towel over your body to provide that physical barrier. And then making sure that we're putting on and taking off that equipment properly so we're not contaminating ourselves. And if we have to change gloves in between those individual animals or between litters. What about foot baths? What about hand sanitizer? And so, well, we talked about contact time. And unless you have time to spend 5 or 10 minutes standing in that foot bath, that is not going to be a reliable means of disinfection. And foot baths have even been shown to be sources of disease spread in shelters. Hand sanitizer, also not reliably effective against all of our hardier pathogens. And so foot baths are a big no. Hand sanitizer, I would argue, not for staff in shelters that are at high risk. They may have a place for the public who are not doing that close handling with potentially sick animals like our staff are, but hand sanitizer is not enough for staff in the shelter setting. Must use PPE. This was a fantastic sign from a shelter that we visited, and so I wanted to share. Again, thinking about who we're using PPE with, right? Our puppies and our kittens are vulnerable and they're our highest risk animals, and so potentially using PPE with every single one of them always. Now, the flip side of this is adopter interaction. And so here are a couple of signs from well-meaning shelters that don't want potential adopters to spread disease. Here's the key, though. We know from the research that adopter interaction is necessary to convert potential adopters into actual adopters. That interaction matters. And so when we put up signs like this, when we discourage that interaction, are we actually preventing those animals from leaving? And if I had to pick one strategy, the number one strategy to reduce infectious disease in the shelter setting, it's to not have the animals in the shelter at all, right? And so if we're limiting their adoption likelihood by preventing adopters from interacting, perhaps we are causing more harm than good. Certainly it depends on the population. It depends on what you have going on in your shelter. But again, the best thing for infectious disease prevention is to get them out, right? And so we have to balance this risk of disease prevention with potential life saving. And so I would encourage you to let adopters interact with those animals. Maybe this is a situation where hand sanitizer actually is okay, right? Reducing that pathogen load and that lesser measure that those adopters or potential adopters will comply with. Okay, very, very quickly, we're going to just briefly touch on behavioral welfare in the shelter. And I want to introduce you to the 5 freedoms. This was a model looking at the welfare of animals. We have made the shift from the 5 freedoms that you see here to the 5 domains. And so the 5 freedoms, for the most part, are freedom from negative things, like freedom from hunger and thirst, freedom from discomfort, pain, injury, and disease, from fear and distress. it is included, freedom to express normal behavior, but we've shifted to this 5 domains model that really looks at provision of positive needs, positive welfare states in order to achieve that. So going from just avoiding the bad to actually providing the good, right? And all of these different domains, nutrition, environment, health, opportunity, or provision of choice, lead to that positive mental state, that positive welfare state when we're able to satisfy all of those needs. And that is what provides that behavioral and physical manifestations of health for our shelter pets. So I encourage you, when we think about provision of these needs, to think about them in terms of that model. What does this mean? Right? Enrichment used to, in some settings, was like a nice thing that we did for shelter animals. Now we are thinking of enrichment as not optional, right, for animals in confinement. This can look like a lot of different things. Can look like human social interaction with other cats or dogs for those individuals that appreciate it. It can be objects. It can be auditory, so things like music or smells, right? No matter what, in shelters, we want to monitor our enrichment programs. We're providing enrichment, but are the individual animals using it? Are they getting what we want them to out of that enrichment? And as with any program that we're putting resources into, what does that enrichment on the population level look like? This is a great place to engage the public and volunteers. And so I have some examples of that, right? Volunteer engagement with stuffing Kongs as an example. Playgroups are a fantastic way to get dogs enrichment. And for those dogs that enjoy the company of other dogs, the goal, right? Every dog, every day, getting them out of their kennels. I will say veterinary professionals often worry about the risk of infectious disease. And so certainly we think about the animal selection, right? We're not going to put dogs with signs of infectious disease in a playgroup with other healthy dogs. But if we're choosing low risk animals that are apparently healthy, right, like that risk is relatively low. There may be situations too where, for example, our respiratory dogs, they're at risk of a much longer length of stay. And we know that stress is going to negatively impact them. So let's make a playgroup for our kennel cough dogs, right? And so even in dogs with signs of infectious disease, potentially we can explore enrichment and even playgroups. Puppies and kittens that we have in our care and shelters, keep in mind their critical socialization windows. For kittens, it's 2 to 7 weeks, and for puppies, it's about 3 to 12 weeks for that primary window. And so it's really important to expose them to a variety of stimuli during this period so they grow up to be well-adjusted adults. And this, again, is why it's so important to get these little ones out of the shelter, right? They're the most vulnerable to disease, and they need these novel stimuli early in life. And so foster care is certainly a great option for that. What about singletons, right? Especially during kitten season, we end up with orphans. And so are there opportunities for us to combine those singletons? And potentially there is for that socialization benefit. We just have to compare the risk, the infectious disease risk, with that life-saving benefit and mitigate that risk as much as possible. Happy to talk about strategies to mitigate that risk outside of this talk, but definitely it is something that we can consider. It's balancing that risk and life-saving. If you're not familiar, I want everybody to know that there's the Fear-Free Shelters program, which is free for all shelter staff and volunteers. And so it's a fantastic program that dives into a lot more of this, including recognition of fear, anxiety, and stress and frustration for cats and dogs in shelters, including these scales. And this gives us a mechanism to objectively evaluate the FAS of cats and dogs in our care, and gives us common language to be able to assess that, as well as being able to document that objectively in our records. Pharmaceutical interventions. I want to highlight a couple of opportunities I feel like in shelters. We have these FAS scales that help us to recognize stress, and I think part of this is the recognition that the shelter is always a stressful environment, right? Whether this animal came from a free roaming, was truly a stray, like a free roaming cat, or came from somebody's couch and was surrendered to the shelter is extremely abnormal and is inherently stressful. And so when we think about opportunities for pharmaceutical interventions in the shelter environment, I think it's important to address some myths and misperceptions, right? Sometimes we hear that we're concerned that pharmaceuticals are going to mask behavior. In reality, right, the shelter is what's masking their real behavior and their real personality. The shelter is the artificial thing, and the pharmaceutical interventions can potentially lower that emotional, address the emotional states that are a result of that stress. Sometimes we hear that we're worried those drugs are going to sedate the pets. And I would say if that is never the goal, right? Maybe sometimes it is if we need to do a procedure, but generally, right, everyday meds, the goal is not to sedate them. If we're doing that, then our doses are too high. That these meds can be barriers to adoption. And arguably, animals that are highly, highly stressed in the shelter setting, they don't present as well. Their mental welfare is poor, right? Because they are so stressed. And in fact, that, in my experience, has been a larger barrier to adoption. And then another myth is that it's difficult to provide post-adoption instructions. I have many examples of shelters that have been able to really streamline this process and provide weaning instructions or tapering instructions, and adopters are really, really open to it. All right, let's shift to a little bit of population management. So I mentioned length of stay earlier. Length of stay is defined as the time that an animal spends in the shelter's care. And typically we talk about LOS, or length of stay, in a number of days. And so why does length of stay matter? Well, we've touched on this a little bit, but it is, again and again, study after study, it becomes the most important risk factor for infectious disease in shelters. We also know the longer they stay, the more stressed they get. They have the potential for behavioral decline. The longer they stay, there's the increased cost to care for them and a decreased ability to save lives over time as they are taking up that housing unit. And so what we see, unfortunately, is this vicious cycle where they stay longer. They end up getting, if they're not sick already, they get sick. They have to wait on medical care. They're less likely to get adopted. And then we go around again, right? Like they stay even longer and they get sicker, and around and around and around. And the whole while they have poor welfare, and it results in more crowding in our shelters, right? And so that crowding then contributes to even more stress and more illness. So let's look at a super simple example of the impact of length of stay on shelter capacity and what daily life in a shelter can look like. So we have shelter A, who has an average length of stay of 3 days. The shelter does 3 intakes per day and 3 adoptions per day. We made it super simple math. Shelter B, same intake, same adoptions, but only 1 day length of stay. And so let's look at what happens in this shelter. So day 1, 3 dogs in to each shelter. Day 2, 3 dogs in, 3 dogs in. Shelter B gets some outcomes, right? They get some adoptions. Day 3, 3 dogs in. Again, shelter B gets some dogs out. Day 4, you see the pattern, right? 3 dogs in. Shelter A finally gets some adoptions today. And then so does shelter B again, of course. And then by day 5, again, 3 in, 3 in, 3 out, 3 out. And so now we've reached what we call steady state, where intakes equal outcomes, right? And so now on to day 6, same thing again. But here we are, like, look at the difference in these two shelters, right? Before those outcomes happen. And even then, right? Like the difference in how many animals are in each of these shelters. And so same number of intakes, same number of adoptions. The only difference is length of stay. They both get to that steady state where intakes equal outcomes. But the daily inventory in shelter A, it's anywhere from 2 to 4 times as high. And that's one thing. If we're talking about like 12 little dogs on a PowerPoint slide, but in the real world, this could be the difference between 100 dogs and 400 dogs. And so that daily inventory, when our length of stay goes up, right, like the difference in that daily inventory is profound. I ask all of you out there, and if you're on, want to answer in the chat, are you familiar with the ASV guidelines? No, tell me more. Maybe they exist, but you haven't read them. Maybe you reference them a handful of times, or this is me, I reference them all the time and have read them very, very, very thoroughly. And so I would say, if you haven't looked at them, I showed you the schematics on housing, but if you haven't looked at them, I would say that's your homework. Take a look at them, like start to flip through. I pulled some definitions from the guidelines around capacity for care. And so capacity for care, the guidelines say every sheltering organization has a maximum capacity for care, and the population in their care must not exceed that level. It means meeting the needs of every animal admitted to the shelter, regardless of how they came in, when they came in, or their age, health status, and personality. And so, what is a shelter's capacity? In its simplest form, we can calculate the number of housing spaces that we have. But it doesn't matter if you have 5,000 dog kennels if you only have 2 staff to take care of them, right? Like 2 people can't take care of 5,000 dogs. And so our capacity can be limited by our staffing levels. And there's also ways to calculate this that look at our capacity for outcomes. Like how many adoptions do we have available? Realistically, how many animals can we move through our system? And so these are different ways to calculate it. We can actually do that math and come up with numbers. And then I would present to you a different example with a little bit of a different math that looks at life-saving capacity over time. So in shelter A, this shelter has 50 dog kennels with an average length of stay of 30 days. And so when I think about limited intake shelters that are pulling potentially from their local municipal shelter, right, this is a really good example. And so if animals in their care are staying for 30 days, they can care for 608 dogs over the course of that year. Now, if they reduce their length of stay to 7 days, they can care for over 2,600 dogs in that year, right? And so when we think about capacity over time, when we reduce our length of stay, we can move more animals through that system over time, and so we can save more lives. This was a study that actually looked at using this capacity for care model in shelters and looked at what that did to cat life saving. And so in 3 shelters, they actually installed portals, and so they reduced the number of feline housing units. And so these shelters operated at a lower capacity than they previously had. The results, the number of cats in isolation decreased, so their cats were healthier. Their average length of stay for cats decreased, and they had an increased adoption and decreased euthanasia in the shelter. And so this is just one example of that when we operate within our capacity, that positive feedback loop that can happen. All right, so how do we manage our populations? And there's a number of different strategies for that. I think strategy, a combination of the things that we see effective in shelters are daily population rounds, as well as a regular sit-down meeting that looks at average length of stay for various populations. We have to know what's happening in our populations, and we have to take action proactively when we're looking at these pets that are staying longer than they should. We have to make sure we're including the right people when we're having these conversations or when we're doing rounds. And so what is daily population rounds? This might be different than other sorts of what we consider rounds or what we might call rounds, for example, medical rounds. Daily population rounds is focused on really managing that population, right? So it's a physical walkthrough of the shelter, every animal, every area, every day. We typically involve somebody from medical and somebody from operations, and then other teams as they are available or depending on the size of the shelter. And our goals are to improve quality of care, minimize length of stay. It improves collaboration across teams, and ultimately, right, our top line goal always is to increase life saving. And even in shelters with hundreds upon hundreds of animals on site, our goal is for this to take an hour or less, and we can do it efficiently to achieve that. So every area, every animal, every day. And this is a set of questions that we ask, like, who are you? So identification, how are you? Both behavioral welfare and physical welfare. Are you where you need to be, right? Do I have a highly adoptable puppy that's hidden in the back area of the shelter where none of the adopters can see it? What do you need today, or what do you need scheduled? For example, vaccines or surgery. How long have you been here and why? How can we get you out of here? And then from a welfare standpoint, are you better today than you were yesterday? When we're on rounds, maybe if it's quick, we'll discuss it in the moment. But for most situations, if it's longer than 30 to 60 seconds, we write down an action item and we follow up later. And being able to do that is what keeps the daily population rounds actually efficient. And so this is an example of a cat that I actually encountered on daily population rounds. This was a cat that was waiting for surgery over the weekend, so she could be returned to her community home on Monday after surgery. And so what are potential rounds action items for this cat? Hide box. Is she scheduled for surgery? She clearly is demonstrating some signs of FAS. And so, as I'm sure you have guessed, the answer, right, is all of the above. So she needs a hide box. We need to make sure that the steps to get her to her outcome are being addressed. And if we can, if there's an option, potentially trying to move her to a quiet area of the shelter. Whenever we talk about population management, I use the word proactive a lot. And so the goal whenever we're talking about managing our population is to be proactive. And so for a blocky-headed gentleman like this, right, we know this dog is perhaps not going to move through the shelter as quickly as we would like. What I don't want to do is wait until he's been in the shelter for 30 days to start taking action to really expedite him on that pathway, right? So are there things we can do earlier in a shelter stay in order to get them along on that pathway, right? So what might we do on day one for this dog rather than waiting until he's been in the shelter for 2 weeks or for a month? All right. And with that, so that is all that I have for our first session today. And so join me again for part 2, where we will dive into some life-saving shelter programs, as well as start diving into particular infectious disease.